Hi, I'm Dr. Tony Mork, endoscopic spine specialist, and I want to ask, is there something inside of the disc that can cause annular tears? I think the answer is yes. There are free-floating fragments inside the disc. These fragments in the disc may be the missing puzzle piece to understand chronic low back pain, at least in large part. Chronic low back pain caused by annular tears remains a huge mystery with significant economic consequences. The causes of chronic low back pain are rarely diagnosed correctly by the mainstream medical community, in my opinion. If you cannot identify a problem, you cannot create a solution. The ineffectiveness of traditional treatments of chronic low back pain suggests it is a complex, multifactorial problem. Traditional treatments of chronic low back pain that are rarely effective long-term include physical therapy, manipulations, injections, traction devices, medical management, fusions and disc replacements. After decades of treating back pain endoscopically, I've generated a hypothesis to account for chronic low back pain and the strange complaints that people have. My hypothesis is that there are free-floating fragments inside these painful discs that cause annular tearing and pain. The purpose of this video is to explain and demonstrate how these fragments contribute to back pain. Let's start with what we do know about annular tears. Since 90% of annular tears don't hurt, there must be two types of annular tears. The asymptomatic annular tears, that's the majority, and then painful toxic annular tears, which may represent 10% of them. Since 90% of people with annular tears don't have pain, most physicians don't consider annular tears to be a significant cause of the back pain. But the remaining 10% accounts for a huge percentage of chronic low back pain. I believe the assumption that annular tears don't cause back pain is inaccurate and has created a very frustrated group of chronic pain patients. Is there a way to differentiate between painful toxic annular tears and asymptomatic annular tears? The MRI scan is the most commonly used tool to evaluate chronic low back pain. Unfortunately, it cannot reveal which discs are painful. As I say to people, imaging studies image. They don't tell you where you hurt. As far as imaging goes, the MRI is considered the ultimate study. But is it really? Take a look at this MRI scan and the disc, the second one up from the bottom. That's the black stripe. It was read as normal by the radiologist, maybe with a little bit of darkening or dehydration, but otherwise read as normal. In my experience, the CT discogram is the gold standard to diagnose painful annular tears. And here we have a picture of the previous MRI scan using a different technique of a CT scan performed after a discogram. So dramatically different appearance than the previous study, and this was the person's painful disc. Annular tear is revealed by the contrast spreading from the center of the disc, the nucleus, to the periphery, like we just saw. Here we see it again. This is you can see the vertebrae sandwiching the disc. The dye or contrast in the disc, which is supposed to be contained, is no longer contained as the dye leaks to the periphery. The CT scan after discography can show annular tearing even when the MRI is read as negative, as we saw in the previous example. The CT discogram can give a very different picture than the MRI, as we also just saw in the example. Here we are once again, comparing the two. We have the 4 or 5 disc on the left on the MRI scan, and then we have the CT discogram on the right-hand side, showing leaking of the contrast out to the periphery and an annular tear. A discogram is performed with sedation and followed immediately with the CT scan. There's also a provocative part of the discogram performed, which helps to identify which disc causes the low back pain. Thin slice CT gives a nice three-dimensional picture of the disc after the contrast is injected, as we've seen previously. The CT discogram can show annular tears not seen on the MRI, as we've just seen in this current example. If the CT discogram is the gold standard, then why isn't it recommended more often? Well, insurance approval for discography can be difficult, while the MRI is almost always approved. Most doctors don't appreciate the things that a CT discogram can show compared to an MRI scan. The question, does the CT discogram get us closer to understanding what is causing the back pain? I believe so, since we now have a test, the CT discogram, that shows a problem that we couldn't identify on the MRI scan. In addition, we can get verbal confirmation of the pain during the discogram. But as effective as the CT discogram is, there is something else that it doesn't show. When looking inside of the painful disc, the something else was revealed by the endoscope. The endoscope revealed free-floating fragments that I believe to be a big contributor to understanding the painful disc. Why is the endoscope ideal to view these fragments? The endoscope operates with positive water pressure to mobilize the fragments that are not seen in the usual situation where the atmospheric pressure is exactly the same in the operative field inside the disc as it is in the room. Free-floating fragments inside the disc that cannot be seen with the MRI scan or CT discogram. Let's take a look. Here I'm pulling fragments out of the disc. They're stained blue because with methylene blue, which we'll talk about shortly. Here's inside the disc, and I'm doing very little to just mobilize a tremendous amount of these fragments. And here they are piling out of the disc with almost no effort whatsoever. The blue stain, methylene blue, indicates that they're stained like this and that the blue tissue is dead. Methylene blue is a acidophilic dye and will only stain dead tissue. Up to this point, the fragments have been an invisible part of the pain puzzle since they cannot be seen with the MRI or the discogram. Here's what they look like floating around inside the disc. We're inside the disc with the endoscope now. And again, I'm doing very little to mobilize all these soft tissue fragments. This is the tubular retractor inside the disc, and I'm just gently grasping any tissue. If you try to grab normal tissue and pull it out, you can't do it. But here we've seen the blue stained tissue underneath this, which is actually the dead tissue. Here's some additional blue stained tissue, as we can see, and all this is just floating around. Again, deeply stained blue tissue is completely dead, and sometimes kind of underneath the more normal appearing white tissue as we get toward the center. Well, here's what the disc fragments look like after they're removed from the disc. And this is a picture we can see with the tissue fragments unstained. And here's a picture when stained. So the acidophilic dye, methylene blue, only will stain dead tissue. And we can see that there's very easy to see the blue staining of this tissue. And in a little bit, I'll be able to show you some microscopic slides of what it looks like without the stain. So again, why is acidophilic methylene blue diluted, placed inside the disc in a diluted fashion? It stains the nucleic acids when released when the cells die. The nucleic acids of dead cells from the nucleus of the disc, when the cells in the nucleus die, nucleic acids are released, and this is what the methylene blue stains. What role do these free-floating fragments play? These fragments might create fissures as they migrate to the periphery of the disc under the weight of the body. And when I say periphery, I mean the annulus covering the disc. The annulus contains the disc and is filled with sensory nerves, as we can see in this picture here. Here we see the disc, and it's surrounded by various nerves of both the sympathetic nerves as well as the sensory nerves in the periphery. As we show here, there's no real nerves inside the disc, and the light gray in the center of this picture is the nucleus, which probably is responsible for the fragmentation when it is either completely or in part separated from its nutritional supply. And then you can imagine that the fragments can actually start to migrate to the periphery, at least responsible in some part for the tears. There's a rich supply of sensory and pain nerves in the annulus, which is, in my opinion, is the source of axial back pain, maybe more so than the end plate theory, which is seems to be much discussed these days. The discovery of these fragments could answer a lot of questions and help solve chronic low back pain. So what else do we know about these fragments? These fragments are pieces of dead tissue. As I said, at one point they were part of the nucleus, which broke off from its nutritional supply. So how do I know that they're dead? This is what the fragments look like under a microscope. And we can see that there's just not much going on, mostly dead tissue. Again, mostly dead tissue. Few, if any, live cells, there's no blood supply, and contrary to popular belief, no inflammation. What causes the fragments and fragmentation? I believe a part of the nucleus is separated from its nutritional supply after an injury, and that injury can be trivial. At this point, one of two things can happen, depending on the size of the fragment. One, if the fragment is large enough, the intradiscal pressure will force the fragment to the periphery, where it can herniate. And here's an example of a herniation. A large fragment inside this disc was under pressure forced out to the periphery beyond the confines of the annulus, and it can be seen on the MRI as a herniation. Two, what happens when the fragments are too small or soft to herniate? There is minimal, if any, circulation inside the disc to allow the fragments to be resorbed. These fragments will die without a source of circulation or nutrition. These fragments become trapped inside the disc and can't get out. Now we have a disc filled with dead fragments floating around and slowly breaking down. These small fragments float inside the disc indefinitely, since they aren't large enough to herniate. These free-floating fragments can cause two types of problems: mechanical and chemical. Mechanical and chemical issues can help to explain the odd complaints that frequently accompany annular tears. Let's talk about the mechanical. Mechanical problems. Loose fragments can move around inside the disc. And people complain and say things like, "My back goes out." This can be a result of a large fragment moving in and out of the wrong place inside the disc. Let's take a look. So we're inside the disc with the endoscope, and all the blue material is dead tissue. But you can see how easily this is pulled out. Normal disc cannot be pulled out of here, but these are large, loose fragments, and you can see with certain motions, if this was able to be moved around, people would have a sense of instability of their back. They would complain, my back gave out, and that's exactly what's going on. Is we're pulling out these loose, dead fragments, and they're pretty good size, as you can see. As I said, if it was normal disc, you could not pull it out like that at all. It just doesn't happen. So here's graspers, and again, I'm not working very hard to get these large, colored, stained fragments out of the inside of the disc. And all these complaints of my back giving way are almost always eliminated when removal of these larger fragments inside the disc.
Okay, so go ahead, just turn it off now.
So these free-floating fragments can migrate to the periphery under the pressure of the body weight. The free-floating fragments migrate under hydraulic pressure, and they create fissures, channels, and annular tears. This is the example of an annular tear. So the fragment would have started in the center, where there's a more intense staining of the nucleus, and then as fragments break off, you can see that you can follow the trail with the contrast out to the periphery. I believe these fissures, channels, and annular tears act like a freeway system to allow lactic acid and inflammatory chemicals to move from the interior of the disc to the sensitive annulus on the outside. And these chemicals and lactic acid and inflammatory agents have been well documented to exist inside of a degenerative disc. So here we are again. Let's take a look. Now that's the epidural space. So we're looking at the back, the posterior, the back of the annulus, and we can see that the stained material actually will go out to the periphery. And as it goes out to the periphery, like you can see in here, we're very, very close to that's the spinal cord. Those the cauda equina right above us. And you can see that as these chemicals and all, there it is. See, I'm just kind of teasing away to show you that these fragments can actually create fissures that will conduct the dead tissue out to the periphery. Here's another example here. Again, it's a little bluer than normal, but we can see that the foam on the top of this, that's going posterior to the back. That's actually the epidural fat. It's inside the spinal canal, and you can see how much staining can occur. This is just methylene blue that leaks out of these discs when you put a little contrast in them. So actually, we're doing the arthroscopy. We've done the work inside the disc, and now I'm pulling back and then going to show you the interval between the cauda equina, or remnants of the spinal cord, and then the back of the disc where the dye is leaking.
Okay, here we go. Okay.
So you can see that this dye, along with all the other contents of the disc, can easily move.
So this is how that stuff leaks out into the epidural space. You can see it just comes right out the back here. This is like one of the better pictures I've ever seen. Are you shooting?
Mm-hmm.
So if the nerves in the cauda equina are here, people can get genital pain, leg pain, and oftentimes with the quality of burning. So again, no inflammation really, but lots of this dye coming out the back, indicating that there's a pathway for any chemicals inside the disc to come back here. This is just a little bit of fat, epidural fat, nothing of any consequence, other than it's just a little bit in the way here when we're trying to look. But you can see all the contrast on the back of the annulus in contact with the spinal canal. So this is
Thank you.
I think answers a lot of questions about people getting these oddball complaints, genital complaints, pain in their legs without a disc herniation, the sense of burning, maybe from the lactic acid leaking out. Lots of possibilities here.
Action.
Okay, the screen pretty well filled up with the picture.
So here it again. You can just see the foam of the epidural fat on the top of the screen. We can see the dye leaking out the back, and the nerves are passing right over this area in close contact to what I imagine is lactic acid or other inflammatory products. Here we are with a little dissector between the back of the annulus and the cauda equina, or remnants of the spinal cord. So the second thing I want to talk about, in addition to the mechanical problems, are the chemical problems, and these are both known and unknown chemical problems. Lactic acid can be generated by disc breakdown, as evidenced by disc pH around 5.5, whereas the normal body pH is around 7.6. And I've taken enough pH samples, from the cases I've done to actually, have confirmed this. So this is an acidic pH, and again, I think when coming in contact with certain sensory nerves gives a sense of burning. I believe the lactic acid can leak out of the disc via the annular tears, which we just saw, and onto the sensory nerves in the periphery of the annulus or the disc, and gives this sensation of burning. If the lactic acid leaks to the annulus and into the spinal or foraminal canal, the lumbar and sacral nerves that pass over the annulus will be stimulated. So, in my opinion, the nerves don't always know the difference between a mechanical pressure of a disc herniation or a chemical stimulation of some of these inflammatory type of chemicals. The sensation of burning can occur in the groin, genitals, legs, and feet. In addition, unknown inflammatory agents can also be byproducts of cell degeneration. In addition, unknowns may be cytokines, bradykinins, TNA alpha that are also toxic and inflammatory. What happens when these inflammatory chemicals come in contact with nerves? Most likely something painful. These channels caused by free-floating fragments may allow whatever is inside the disc to migrate to the periphery and out through the annulus. This means that byproducts of degeneration can leak onto any nerve, and that includes both sensory nerve, motor nerves, and sympathetic nerves. And this is what gives these people such a confusing history oftentimes when talking to them. So, an interesting fact, this really answers the question of how can people have radicular pain, that is pain radiating down their legs or in the feet, without a disc herniation. And I think that this explains it very well. Well, what about the treatment for this problem? I think that treatment should be directed at the problems that I've identified. Dead tissue fragments floating around the disc and abnormal chemistry. At this point, we can defer to some basic surgical principles. The best way to encourage healing is to remove dead tissue. This is why I recommend an endoscopic washout to remove dead tissue and debris from the inside of these discs that are painful. This may explain why intradiscal injections alone may not solve the back pain, because the problem, or at least one of the sources of the problem, the dead tissue, has not been removed yet. This washout can assist the healing process, which is slow because of the poor blood supply and acidic environment. Poor blood supply also leads to a very low oxygen content, healing potential, and another reason why things like stem cells may not work very well. The recovery can take several months for these people. Remember, the goal of surgery is to reduce the pain, not to immediately get more active. And just remember that sitting is usually the worst position because it generates the highest intradiscal pressures. So changing positions is very important post-op. Walking is the only exercise I recommend for the first 6 to 8 weeks post-op. No stretching and really no type of lifting more than 10 to 15 pounds, and really just minimizing motion of the back. One of the problems with the back in general is that it really can never be still. Even when you're laying down, it's moving around. So minimizing back activity while the chemistry and healing process is starting to take place is just essentially best facilitated by walking. Thank you very much for watching this presentation. I hope that it sheds some additional light onto a very difficult problem, chronic low back pain.